We are all set now, sir.
Okay. All right. Dear colleagues, participants from home and abroad, students of IUBAT, and all other participants, Assalamu alaikum and good morning and good evening. It's my pleasure to welcome you on behalf of Public Health Cafe. My name is 𝗛𝗲𝗵𝗁𝗲𝗵𝗁. I am former Director General of Department of Family Planning under the Ministry of Health and Family Welfare. And you are aware that the webinar is organized by the Department of Public Health, IUBAT, College of Nursing, Public Health Foundation, Health Systems Matter, and it is held once in a month on different important public health issues. And today's webinar is being chaired by Professor Dr. 𝗛𝗲𝗹𝘁𝗵. He is the chair of Public Health Department in IUBAT. Before joining here, he has more than 20 years of global leadership experience in public health. He worked as senior leader at the Gavi Alliance, Management Sciences for Health, and Gender Health USA, and so many organizations he led. So his expertise spans health systems and global health policy and public health education. And I am very pleased to introduce today's keynote speaker, Dr. 𝗧𝗻𝗻𝗁 Ahsan. 𝗧𝗻𝗻𝗁 Ahsan will be talking on a gendered human security perspective on refugee and migrant health, evidence from Rohingya refugees in Bangladesh. I think it would be a very interesting presentation. And Dr. 𝗧𝗻𝗻𝗁, she is gender and result-based management expert. She obtained her PhD on public policy from Australian National University and MSc in policy and development from London School of Economics. She has many virtues to mention here, but I have to cut short. And she is expert on evidence-based programming in global development. And we are also happy to introduce our panelist, Rotarian Dr. MD Mothiur Rahman. He is Deputy Executive Director and Chief of Health Sector at TMSS Bangladesh. He is a PhD degree holder, he is a physician, he has also MPH. So all this knowledge was instrumental for establishing a number of health education institutes like TMSS Medical College, Nursing College, and so on. We have another panelist, Ms. Tasmia Tabassum Rahman. She is expert in gender equality and social inclusion. And she is expert on research and innovation. She is portfolio advisor at Innovation Consulting. She obtained her MSc in Social Policy and Development from London School of Economics. We have another panelist, Ms. Halimatu Sadiya. She is development professional, expert in research, innovation, and fundraising, one of the daunting tasks. And she is head of growth of 𝗱𝗲𝗄 Foundation, and she received an award, Feminist Leadership 𝗬𝗲𝗄 Global 2024. So all are very illustrious personalities here today. We'll listen to them, but you are aware that time is so short that we'll listen to the presentation first, and then I will invite the honorable panelists to give their reflections, insights. Meanwhile, there may be question and answers that could be placed in the chat box, and the experts will try to answer to those questions. And finally, we'll listen to the chairman of the webinar, Dr. Professor Sheikh Nazmul Huda. So I would humbly request the keynote speaker, Dr. 𝗧𝗻𝗁𝗁 Ahsan, to please start her presentation. In the meantime, we have very honored participants from abroad. John, Alex, respected, they are the teachers of IUBAT. You are all welcome. And also the students of IUBAT, MPH, those who have sacrificed this evening to attend this webinar. So, Dr. Monira, please start your presentation. Thank you.
Thank you so much. Good morning, Assalamu alaikum, good morning and good evening, distinguished colleagues. Let me begin with a simple but critical question. Are health services truly accessible if gender determinants who can use them? Today, I argue that to understand refugee and migrant health, we must move beyond systems and statistics. And instead, we need to examine power, access, and lived realities. So, a gendered human security lens shifts us from services delivered to who can actually access them and why and how. So this is my argument. In this presentation, I will reflect on the key social determinants that shape refugee and migrant health access, health services, and health outcomes. So let's begin the main presentation. Can you see it?
Yes,
Okay.
I can see.
Okay. All right. Okay. So the key hypothesis that I have set for this study, as we know that the refugee humanitarian context has become so protracted, the influx of 2017 and now it is 2026. So it's going to be 10 years soon. So it is very critical moment for us to reflect, to pause and to reflect, to review how the humanitarian health is working. So for this paper, my key hypothesis is the lack of refugee policies and procedures increases gender-specific human insecurity among Rohingya refugees, as well as basically host communities as well. Consequently, current refugee governance might reinforce the hierarchical models of social, cultural, behavioral, structural, political, and legal factors as social determinants that affect refugee health and well-being without consulting refugees and others, including the host communities. As a result, refugee girls, women, gender diverse individuals, people with disabilities, the elderly, the adolescents, and youth, including all other population in that context, are especially vulnerable because their voices are completely overlooked in the process. Sorry, why it is not shifting? Excuse me. Can I just... Okay. If we just briefly look at the Rohingya fact sheet without going into detail, just to highlight the key...
Madam,
hello?
your screen is not visible to us.
It's not visible? Okay.
Yes, it is not visible to us.
Okay. Is this visible now?
Yes,
Can you
visible.
see now?
Yes, yes.
It is okay.
Yeah.
So the key...
Perfect.
Sorry. Okay. So the key figure, very briefly, over 1 million Rohingya refugees have been living in in Cox's Bazar since 2017. Little over half of them are women, and majority of them are a big number of them are children below the age of 18 years. In terms of looking at the health aspect, the doctor to population ratio is 1 per 40,000 people, which is far higher than the global WHO standard, and the nurse to population ratio is 1 per 20,000. Approximately 10% of Rohingya refugees face unmet essential healthcare needs in terms of consultations and medications for acute illness, management of chronic conditions, and preventive checkups. Without going further details, because it's a huge subject, I would like to highlight the key determinants in the form of human insecurity that shapes refugee and migrant health. I'm sorry, why it is not shifting? Can you see?
No, only your laptop screen.
Okay, sorry. Can you see now?
Yes, we can see now.
I don't know why.
Dr. Monira,
Yes.
if you hover over it, there's a like arrow in the left bottom that should like change the slide. Once you start the screen sharing and go to the presentation mode, there should be some arrow mark on the left bottom.
Can you see my screen?
Not
Hello?
yet. We can
Not
see
yet.
you, but not your screen.
Not the screen?
No.
Mm. Can you see now? Can you see now?
No.
Not yet. Not yet.
Who is controlling the screen?
Actually,
No
I'm
one-
trying to do that.
No one technical person there?
Um,
Are you yourself moderating?
yes, I'm just moderating from my side, and it never happened.
Oh.
Is this visible now?
You are visible,
The,
but
the
your
screen is not visible.
Shojib is there.
So
On the tape.
you share your file, you share your PP slide.
My
And it will
PP
be
is with, yeah, my PP is already there.
No, please again come out and then again re-entry. That will solve the problem.
Okay.
Ma'am, let me try sharing my screen.
Yeah.
Though I have joined from
Sajad,
you
you
see
can
now?
also take the
Can you
files.
see now? Can you see now?
No, not yet.
Okay. So is this possible, Dr. Sajjad, to share your screen? The presentation is with you.
Sajjad, can you try from your end?
Still you can't see, right?
Now, Shahadat is the host. He can actually help.
So you cannot see my screen, right?
No.
No.
So, you-
Okay. So
you
yeah.
you can give the slides to Shahadat.
Yeah. It's
Shahadat can help you. Yes.
Yeah. That's the PPT is with him.
Okay. Okay.
Sorry.
Not to
about
worry. It will pop up. Yes,
Actually,
soon.
actually, Iyako was absent. Now I requested him to join, and he's trying to join. I think he can help. Yaqub, can you now? Are you available? Yaqub?
Oh, one after another host is changing, but anyway, now solve.
Yeah. Okay.
But the host should have the slides.
Assalamualaikum. I'm coming now. I think it will be solved. So we again start
Yeah.
our webinar.
Hard to share the screen, Yaqub, please.
So this is the last time I have tried. Can you see my screen?
Okay, the problem can be occurred.
No,
No.
madam.
Okay. Sorry
Please,
about that.
Please start again. Please start
Yeah.
again. I hope now problem will be solved.
Restarting is going to help you.
Okay, so should I close? Should I
Yeah.
come out of
Yes.
Zoom?
Yeah.
Okay.
You
Sorry
leave
about that.
leave the meeting and then join.
Yes. That's going to solve the problem. I hope.
Meanwhile, welcome, Professor Aftab.
Oh, welcome everyone. Warm welcome to Alex and others, Richard,
Thank you very
everyone.
much for joining.
Everyone. I just came back from the mosque.
Okay.
And then I thought, okay, maybe not too late, 10 minutes only.
Yeah.
Anyway,
Yes, no
technical problem helped me a lot now.
Yeah. Sometimes the problems open the opportunities, right?
Right. So, Alex, how are you? After a long time.
It's nice to see you again.
Hey, me too. Thank you very much.
Can you share, see
Yes.
my?
Yeah. Now we can see your slide
So
clearly.
go in the slide mode. Yeah, presentation mode.
Yeah.
Okay,
Good.
so
Bye.
moving faster, I would like to begin with giving you a glimpse of refugee life. So this is basically a clip. Okay, so this is, again, this happens that I cannot move. So you have seen the refugee camps are frequently affected by fire. The last one that we heard in January this year and March this year, the video that I have shown you, it's from 2024 when I carried out my postdoc field work, basically. So that was post, fire incidents. This is another incidence of landslides. And this morning I have received another video where, due to time shortage, I'm not going to play that little clip, but three refugees, two of them are adolescent boys and one of them was adult men. they were kidnapped and demanded for huge ransom. So this kind of incidences and stories that I heard again and again every time I went to do my field work. So I'm not sure how am I going to move forward. Okay, so that so this is the context that refugee basically live, and why I have emphasized to show to argue that instead of only to what extent health services are available, the quality of health services, we also need to consider the social determinants. And one of the key social determinants are the social aspect, the political aspect, the environmental aspect, the economic aspect that I'm going to highlight one after another in this presentation. To continue this study, basically, I have drawn on my different research experiences at different stages of my over the last almost 7 years, from 2019 till 2025. I was at Cox's Bazar on and off most of the time. So most of my data are drawn from my different studies. Some of them have been published as well. Most of them are commissioned studies. And the conceptual framework that I have used here is feminist methodologies, decolonial approach, and human security. It is not moving forward. Okay.
It's not. It's not a problem from our side. All of the seating are okay. Maybe any technical issue happened from your side.
Yeah, it could be, but since I cannot figure it out, I will try my best to move as faster as possible. So why gendered human security? The key evidence gaps that this studies, tries to highlight. The human security that I have briefly mentioned, the key determinants are the economic security, food security, health security, environmental security, personal security, community security, and political security. And the gender disparities along the human security dimensions that I have mentioned here. And these are basically the human insecurity dimensions. These 7 dimensions are basically, as we understand them, as the social determinants of health. And in the context of forced displacement, as per the so the human security, this concept that I have drawn on from the Human Development Report 1994, that basically defines the freedom from want, a developmental security pillar, such as the economic security, food security, health security, and environmental security, that basically ensures safety from threats of hunger, disease, and depression. And then the other security, basically the personal security, community security, and the environmental security. So those basically ensures freedom from fear, a protective human security pillar. Those pillars are called the protective pillar, human security pillar. They ensure protection from sudden and hurtful disruptions in daily life patterns in home and or communities. So if we look at very briefly how the economic insecurity plays out in the Rohingya refugee context, here I have drawn 2 quotations from my 2 different studies. In the beginning, in 2019, when I did my field work for UNHCR Commission study on gender, to do gender analysis in humanitarian context, I was told by one of the key informant, basically who is the Refugee Repatriation Commissioner of the Bangladesh government at that time, and he's still there. But now, so he said that the Rohingya men with big sticks started putting barricades on the roads so that Rohingya women could not go out to work at NGOs. Okay. So this means even though the humanitarian response created opportunities for Rohingya women to participate in economic activities, they were actively obstructed by their fellow men to participate in the economic activities in the Rohingya camp. The situation has reversed from 2019 to 2024. For example, in 2024, when I went back to the camp again to do my postdoc field work, I heard that unlike in the past, men now encourage us to engage with multipurpose women's center or NGOs income generation activities and earn an income. However, all the empowerment projects target women, leaving men frustrated, which also causes gender-based violence at home. So if we analyze these two quotations, we can see that on the again the gender elements are strongly present even for women's and girls' participation in economic activities. Apart from women's obstruction from gender perspective, there are structural barriers that prevent refugee people from accessing income. For example, refugees are not allowed to earn a living. They are allowed to do voluntary work, and NGOs and UN agencies, they pay Rohingya refugees as honorarium as to compensate their voluntary activities. So by that name, in the name of voluntarism, in the name of honorarium, they get little money, but that doesn't basically ensure their living cost because the humanitarian assistance is minimal. So my key argument here is economic. One of the key insecurity that Rohingya refugees have been experiencing since the beginning, and that is getting more acute and acute day by day, following the donor funding shifted from Rohingya refugees to other more appealing humanitarian responses globally in other parts of the world. So economic dimension is one of the key dimensions that basically contribute to poorer health and other well-being for refugees. Okay, so and then the food dimension, the food insecurity. This data that I have drawn from my study that I mentioned earlier, where food was mentioned as one of their first top priorities. Okay, the second top priority is again food. The third top priorities they mentioned again was food. Just to mention that in the past, due to donor funding crisis or shifting donor priorities, the allocation of food allocation was reduced, cut down from USD12 to USD8 in 2024 and 2025. And in 2026, late 2025 and 26, it cut down from 12 to 6 per month per person, leaving the Rohingya with 20 cents to meet their daily food needs. After huge advocacy, the food ration has gone up to 12 again, but we don't know when again it's going to cut down from 12 to 6 again. Okay. So now I'd like to highlight the health dimension. I wanted to highlight health later, but since it is set here, so there are a lot of health consequences due to various insecurities that contribute refugee poor health. Here, I have taken this data from one of the health service providers, Ganashastha Kendra, from, so this particular data was from camp E4, in camp number 3 and camp E4 in 2023. And this is the annual data and how their disease variations in different months. Okay, so this is the similar data from another camp, 2022. Here, very briefly, if we see that there is a gender disparities in terms of access to health services, where the number of male is much higher than the number of female, and age categories, if we see that the above 5-year number of health intake, the people who received health services above 5 years, where the number was higher than below 5. Okay, so for example, these photos that I took in my postdoc fieldwork in 2020, early 2024, basically. So this is an accumulation of different insecurities that causes poor health. So for example, a lot of women and girls, they suffer from lots of skin diseases, and this is acute, that you can see that the whole hand is covered with skin diseases, Okay, and in terms of and how to talk about gender and how gender influences accessing health services. For example, we asked whether in terms of accessing health services, how access to resources shape women and girls to access the health services. We see that majority of women do not have access to resources, and resources in the way whether they have access to income, whether they have access to and control over decision making and all these things. We saw that a majority of women did not have access to various resources. And women need permission to access health services. So the majority of women need access. They don't have access to and control over decision making. That also shapes their access to health services. Okay, and moving forward to environmental dimension, that also hugely contribute to poor health. So again, this is drawn from 2020 studies, and I interweaved with my recent fieldwork in qualitative data that I have also found that similar situations still persist. For example, sanitation was there one of the top 3 choices. Sanitation was identified as higher. Other factors that affect poor health is insecure access to clean water and safe sanitation, salination, air pollution, natural disasters, cyclones, floods, landslides, etc. And women and girls, they basically have to access to water. They have to collect water, which also pose various forms of threats and insecurities, including GVV. Environmental dimension that I also mentioned briefly here. For example, latrine is placed in unsafe places where women and girls, particularly at night, find it difficult to access. I'm moving faster so that I can have some time for discussion. So personal dimension, for example, the women, particularly women and girls, are at serious risk. For example, here I have drawn a quote from my 2024 study. At night, we, the men, have to remain awake the whole night in different points of the camps to guard against the terrorists who kidnap us, rob us, and kill us. We live in constant fear, but again, we remain fearful leaving our wives and young daughters at home. We fear that they might break into our houses and loot our belongings and rape our females. So the constant fear of attack, killing, rape, abduction cause tensions, uncertainties that also cause to poor health. Other aspect that I would like to briefly mention that in refugee context, these are the issues like gender-based violence, intimate partner violence, domestic violence, forced marriage, rape, forced prostitution or transactional sex, human trafficking, and threat of withholding or reducing humanitarian assistance. All these elements basically constantly shape refugees' health and well-being in different ways. So these are the personal dimensions of insecurity. And the community dimension, the personal and community, there are overlaps between personal and community dimension. Here, I'd like to highlight again some of the quotes from 2 different studies. We have noticed significant changes in our health after the Rohingya influx, as we are now suffering more from various diseases compared to the past. So this quote I have drawn from male host community. Another male says that we live in fear that they might attack us at night. In contrast, in 2024 study, the Rohingya man says the men from the host community forcibly take our daughters and return them after a few days or weeks. We remain fearful about the security of our women and daughters as well as our very existence. So the first quote, it shows that after the influx, the health of the local community has been affected because of they are fearful that they might have infected with STDs and HIV and all these things because of Rohingya influx. And the situation is same for Rohingya women and men as well. And the community dimension and the second quote, it shows that it is not a direct health code, but how it affects the health of the Rohingya refugees, the mental health, the psychosocial aspect. And the political dimension, the gendered human insecurity in terms of political dimension. So since Rohingya refugees are not legally identified or legally accepted as refugees, instead they are termed as forcibly displaced Myanmar national. As a result, because of their illegal migration status or illegal migrant status or an absence of refugee status, which causes political insecurity affecting all dimensions of human insecurities of the displaced Rohingya refugees in Cox's Bazar. So this is, for example, this is a little evidence how their identity is shaped politically. So how this situation has implications for research policy and practice. Here I strongly argue taking a systems perspective and a systems approach to address refugee health. I would like to highlight here one thing, which is the core of this argument. We often do not understand the community. Our work is very meaningful, yet very tokenistic. So that quote I have taken from my 2020 study, and this quote was from one of the key UN agencies. So this means when refugee policies and services are drawn and designed, their perspectives are hardly taken into account in designing any policies and developing any services. So specifically, what implications I have drawn for this, paper is adopting a systems perspectives in health and a whole of society approach that helps strengthen the refugee and migrant health system by ensuring inclusive access to health, access to health services, receiving services and health outcomes. Secondly, both humanitarian development and peace and conflict adjustment policies and programs must understand and address the intersectionality of gender and displacement underpinned by the human security lens that I have introduced here, and respond accordingly to reduce gaps in status, opportunities, access, and refugee health and well-being outcomes. Thirdly, need to foster greater coherence and collaboration across the humanitarian development peace nexus with implications for donor support and sustained funding. And finally, the needs, priorities, aspirations of affected communities, which is the Rohingya refugees, including women, men, girls, boys, older people, people with disabilities, gender diversities, and individuals from diverse backgrounds, must be directly engaged through community consultations to generate evidence for shaping policy and to shaping policies, programs, and services. And finally, sorry. Anyway.
I think that was the last slide,
Sorry.
Dr. Muniera.
Yeah.
That was
I
the
think,
last slide.
yeah, that was the last slide anyway.
Yes.
So, so I think finally, I wanted to argue that policy advocacy is one of the key aspects that we need to take into consideration, and policy advocacy at both local, national, regional, and global levels to shape policies and services, because this is a transnational issue. So no amount of local or national effort can basically address this refugee and humanitarian health in general, and overall refugee issues, Rohingya refugee issues in particular. So thank you so much for listening, and welcome, for any questions and clarifications.
Thank you, Dr. Muniera. It was an excellent presentation. Although there were some problems, but still we found that the slides and the issues are very interesting. We are running out of time, so I would like to go to the panelists first, and the panelist Ms. Tasmia Tabassum Rahman. Would you please reflect your insights?
Yes, thank you. Can you hear me?
Yes.
Yeah.
Okay, great. Thank you, Dr. Muniera. I think this was a really holistic approach to looking at, the sustained problem that we see in the Rohingya community as well as the host community. And while my short but effective bio was given, one experience that I had working for BRAC Skills Development Program was that we did design skills and livelihood-based programs for the Rohingya community as well as the host community. And the point that Dr. Muniera is making is so important, yet we can see that this is being sort of ignored, or there are larger problems that are kind of sidelining this issue. But apart from what Dr. Muniera has mentioned, I think a few things that are really concerning is that when the health concerns are so high for women, the reproductive and mental health challenges are really, really acute, is what I kind of experienced in the field work. And there's a lot of physical injury apart from the skin diseases that you say, a lot of physical injuries from intimate partner violence, and a lot of trauma around that because they have faced huge trauma while coming here, and then they continue to face this. Now, while these issues are so real, my take on this understanding of looking at security perspective and policy aspect globally and locally has two really important aspects. How do we bring that into the agenda? Because right now there are so many. And during the Rohingya community earlier crisis, we did receive funding, sizable funding from the Arab region, as well as larger funding from the US and similar partners who now discontinue or continue with less amount of funding, given that their status for working is still undecided. How can we bring this up into the agenda? That is a question I pose to other panelists as well as you. And the second one is, while we look at the policy and security determinants of the challenges you say and mention quite comprehensively, I think one needs to also look at the informality of the camp and host community relationships.
Okay, thank you. Thank you.
Thank you.
Tasmia. In fact, it was very interesting reflection from you, but unfortunately time is not permitting. So the next panelist will note the questions, and the keynote speaker may like to answer the questions at the end of all panelists speak. So this time I would request Rotarian Dr. M.D. Mothiur Rahman. Would you please finish your reflection within 2 minutes? Thank you.
Thank you, moderator sir. And special thanks to Dr. Munira Hassan for his choosing the very important and very time-demanding topic to present in this forum. So Rohingya and the refugees are the global problem, we know, and this is a huge number of refugees all over the country, all over the globe is living. And low and middle income country, we are suffering with a huge number of refugees compared to the developed nation. So Bangladesh is the worst sufferer of this Rohingya impact. It has both local, regional, and global impact also. So just I am going to a few specific points on the research. So I think Dr. Munira can consider a few things on his research. First, the title. I think what I understand that title is the refugee and migrant. I think there is some different definition of refugee and migrant. Migrant may be the other purpose, but refugee are forcefully displaced people. So this is, I think, a bit different. This is one thing. And next one is that first you just mentioned the hypothesis you draw that lack of refugee policy increase the human insecurity. Definitely, this is, I think this is a hypothesis, but I think this is proven. So it can be considered for either you can consider it as a hypothesis or not. Your focus key word is the health. So you put other dimension also. This is the political, this is the social and other thing, but it has some interrelation. But basically, the health is the main thing. And regarding your methodology, you mentioned some methodology, but cannot mention the how many the number of the participant participated in your research. So that should be, I think, the sample size is not mentioned over there, and what kind of distribution of the sample. So other is that as it is a very sensitive area, sensitive issue. So ethical information is, I think, it should be incorporated in your paper or study. And next one is that you mentioned that this is, I think, the area where the refugees are living. So what we just understand from your information data and the secondary data also. But what about the local community? you mentioned some that the indiscipline activity, some illegal activity on the refugee living area. But what about the local community? I think there should be some comparison also in between the refugee and the local community, and also the refugee in the other part of the globe, so that either this is the policy level disparity or other dimension of the disparity we can better understand. So I think again this is a very important study, and it gives a lot of insights about the refugees, not only the Rohingya but also the other refugees all over the world, and what the global policy making and global initiative can mitigate and prevent this type of political crisis, and prevent this thing and manage properly to help the host countries to better understand and better management of this crisis. Thank you, sir.
Thank you very much. Now the panelist is Ms. Halimatu Sadia. She is head of growth, 𝗚𝗲𝗃 Foundation. Your time is maximum 2 minutes. I'm sorry to mention that.
Thank you so much, sir. Thank you, Dr. Moneera Ahsan, for such a powerful and evidence-based presentation. And thanks to my fellow panelists for raising such critical points. I would like to start with one of my experience. This session took me back to my university days, and I'll share just one instance. I'm a gender studies postgraduate, and I remember in our very first class, our faculty started with a single phrase: women are considered as the poorest of the poor. And she spent over a month educating us on that one sentence. And she was able to prove that me, even coming from a privileged home, I was still being seen as the poorest of the poor because the system was not built for me. Even with the citizenship status I have, the education, safety, the ladder of society still had me at the bottom. Now, I would like to invite everyone to imagine that a woman who has no citizenship status in Bangladesh, who fled her home in fear of her life, who came here just to survive, what level is she at? And Dr. Moneera's research gives us a devastating answer, that she isn't just at the bottom of the ladder, she is off the ladder entirely. And so what do we do here for her? From my experience with feminist activism and also from development work, I would like to say we don't do anything for her. We do it with her. This is the very basic of any program or policy design. We ask, we listen, we understand, we contextualize, and then we design. And while implementing, we must be humble enough to change with feedback. And this is what we have been doing at our organization, 𝗚𝗲𝗃 Foundation. And I would like to share my feedback in 4 points, 3 from program design perspective and 1 from fundraising perspective. Dr. Moneera Ahsan has said that in the camp, we have only 1 doctor for 40,000 people. And I'd like to mention that at the same time, we have to remember that our national data is also not at a satisfactory level. We have only 7 doctors for 10,000 people here in Bangladesh. So at 𝗚𝗲𝗃, what we are trying to do, we are also taking a whole society approach, and we are trying to solve the resource service delivery through the integration of technology and AI in primary healthcare. So we want to make sure that we have breached the gap where human resources are stretched thin. And the second point is integrating the gender transformative lens. I don't know, whenever we talk about gender, we focus on educating and empowering the marginalized people, the women, but we must ask, are they the perpetrators? Are they the blockers? Often they are neither. So we need to understand the root of the resistance, and true growth for me means focusing on educating and including the people who are the actual blockers of progress. And the third point I want to make is making sure the impact is at scale and also at the individual level. When we see statistics such as 100% of the people with disabilities face barriers to healthcare, and almost 90% of the women feel unsafe and they don't feel secure, we must look at impact not just as broad statistics, but as the lived experience of the individual. If a woman feels unsafe at a latrine because there is no lighting or lock, our scale means nothing to her. And the fourth and final point I want to make is, as a fundraising professional, my note to our funding partners is this: please know the concern of the people you want to serve. We need you to spend on research to truly understand these shifting gender dynamics. We need you to spend on infrastructure. And note that by saying infrastructure, I do not mean buildings. I mean the invisible infrastructure of safety, access, and power that provide the human security these people deserve. And if we really want to see real growth, we have to stop treating refugees or migrants people as passive recipients. We must treat them as the experts of their own lives because they have lived it, we haven't. And we must stop designing for them and start building a human security framework with them. Thank you. Thank you so much, everyone.
Thank you, Halima, for comprehensive reflection from your end. I would like to request the presenter today, if you have noted some points, you can clarify. And after that, if there are any other questions from the audience, they can also raise. But we have only 1 minute to finish. So the key presenter, do you like to answer a few?
Yes.
No?
Yes, in a few moments.
30
Firstly,
seconds.
okay, thank you. Thank you so much for all the, all the commentators who have made excellent observation. For example, Ms. Tasmia has rightly pointed out how can we take this agenda at the global level. My first response would be to generate evidence. Evidence would help us to make an argument at local, national, regional, and at global level. So I would emphasize to generate evidence to place the agenda at on the table at different levels to make a difference. Moving faster to address Dr. 𝗪𝗪𝗻𝗁's many points, I fully agree with you that very briefly mentioned that since I have drawn different findings from my different studies, so I could have mentioned the number of participants, number of sample sizes, the distribution of samples, that definitely I will address them in my future presentation where it is possible. But here definitely I could have done that, which I have missed. And thank you so much for pointing that out. And many other points that you have mentioned, and I will take them into account in my presentation next. Going to Ms. Halimatu Sadia, wonderful. You have rightly identified 3 key aspects: taking a gender transformative approach and addressing men and boys who are the key players in shift in gender transformation approach. Taking a gender transformation approach needs addressing men and boys as well. And finally, you have said that we need to make sure that impacts must have to be at a scale and at individual level, which is very important. And in order to do that, we must listen to the people we are thinking to address their problems, which is the Rohingya refugees as well as the host communities, because both the communities are very, they are linked to each other and their issues are pretty closely related. We cannot basically single out issues of Rohingya refugees from the issues of host communities because they are impacted each other's in different ways that contributes to health and well-being. Thank you.
Thank you very much, Dr. Monira. I understand there may be some more questions from the audience, but due to time constraints, we cannot address all the questions, but they are requested to write their questions in the chat box, which may will address later. And now I have the honor to request the chairman of this session, Professor Dr. Sheikh Nazmul Huda, to give his insights. Professor Dr. Nazmul Huda, chair of this session.
Thank you, sir. I would like to take, just maybe maximum 2 minutes for making 2 points and to say thank you to you. The 2 points are, I learned a lot from the presentation and the reflection of the panelists. But just to add 1 point from my side, that there are at least 2 emerging issues when we think about the measure the safety and kind of, protection or of the refugees, of the migrants. There's 2 things, sir. One is the cultural safety. So perhaps it's one of the emerging issue. I can give you an example of cultural safety. For example, I found that one patient of fistula, VVF, vesicovaginal fistula, she was leaking. She was reluctant to take treatment, surgery, because I found that she does not eat onion. So she was afraid that in any hospital, perhaps all the food are with onion. So there's cultural safety. It might be, the same thing might be true for the refugees. The other thing is also the spiritual or faith security of the refugees. And I think these 2 things may also be related to, public health might have a stake in these 2 things also. So, and then lastly, I'd like to thank Mohil sir for moderating this event very effectively, as usual. And thank you, 𝗲𝗲𝗃𝗁𝗃𝗃𝗃𝗃 appa. I learned a lot from you. I know, it was very informative, and thanks to our learned panelists, Tasmia appa, then Dr. Motiur Rahman Bhai, and also Halima appa. And we have 2 very distinguished, what should I say, our patron from the other end of the globe, Alex Barland and John. Thanks, Alex and John, for your support in hosting this webinar regularly and with everything. And our partners, thanks to the leadership of Public Health Foundation. I know Aftab Bhai is here, Shadat sir, and also Sejar. Thanks to you and other colleagues. Shajib worked a lot for the event today. And thanks to Spriha leadership. I know Tajin Bhai joined today, a very busy person. Thank you, Tajin Bhai, for joining us. And from College of Nursing, who joined this event, I thank you. And our students and Shajjat worked hard for the event today. So thanks, everybody. I hope we'll see you again in the next seminar. And I hope that you enjoyed the event today. Thank you very much.
Thank you.
Thank you.
Thank you very much. Finally, I want to read out a sentence said by Justin Trudeau. He said, "Gender equality is not a women's issue. It's a human issue. It affects us all." So thank you very much, learned participants and speakers and panelists. Hopefully we'll be meeting with another important public health issue in future. See you again. Thank you very much, and we are grateful for your participation. Thank you. Bye.
Thank you.
Thank you. Thank you.
Thank you.